Hi, I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and this is Two Shrinks and a Mic.
First, I'd like to give a shout out to my grandson, Levi, who is 10, who just informed me that he's been listening to our podcast from camp, which I'm amazed that a 10-year-old would be listening. I'm going to have to test him to see how much he's learned. But today we're going to talk about a topic we've raised before on occasion, but from our view, it's become more and more central to a lot of psychopathology. Psychopathology is the concept of ongoing problematic emotional, psychological difficulties that can develop. And trauma, it turns out, when you look for it, has been really central to a lot of underlying the emotional difficulties, whether they be depression, anxiety, relationship problems, maladaptive personality traits. And I think I mentioned before, I got interested in the role that trauma plays probably about 35 years ago. I was consulting to a women's substance abuse rehabilitation facility in Delray Beach, Florida, that was unique in that it was sponsored by United Way. So it was not an insurance for-profit type of facility. And so the women they ended up getting there were women who had lost everything because of drugs, lost their families, lost their jobs, lost their self-respect. And they really had hit the bottom of the barrel of life function. And when I got to meet many of these women and doing consultations there, I was amazed at the percentage of individuals who had had traumatic life experiences, whether they were childhood related or young adult related, but they were significant. And I began to realize that trauma plays a core role in a lot of different problems in our field. And that's when I became more sensitive to looking for trauma, because if you don't look for it, you're not going to hear it, because most people who have been traumatized for various reasons will keep it to themselves and not want to share it because they're embarrassed, or their brains hide it in the deep recesses of the brain. So today we're going to continue our discussion about trauma.
You know, the concept of trauma and the treatment of it has kind of come full circle. Back in the 1800s, I think it was the late 1800s or maybe early 1900s, Otto Rank talked about something called birth trauma. And his theory was that the actual experience for the baby coming down the canal and coming out into the real world was our first experience with trauma. And depending upon how that went, he proposed that future psychiatric problems, psychological problems might ensue. Later on, the DSM, our diagnostic manual, talked about trauma and PTSD, post-traumatic stress disorder, and was very, very rigid about the definition of trauma. It had to be something that was either a natural disaster, like an earthquake, or witnessing a murder, or being assaulted, something very severe, but not just a normal human experience. It was considered to be, had to be beyond the range of normal human experience to be traumatic. Then with the concept that was used in psychoanalysis, the concept was that if you're having problems in the present, there must have been some sort of trauma in your past, whether it was a traumatic relationship with your parent or some sort of event or difficult situation, sexual situation that was so traumatic that your brain repressed it. And the concept of psychoanalysis was to unrepress whatever this trauma was that you've suppressed. After that, after psychoanalysis started to lose its center stage in our field, we then focused more in on the present. And that's where cognitive behavior therapy and psychopharmacology really focused on. We didn't ask too much about the past. We considered it to be almost irrelevant to what was going on in the present. And that further caused, as you were saying, David, us to not pay much attention to trauma. And we stopped asking about trauma because it was considered to be in the person's past. And we don't talk about the past so much. So in the last number of years, things have, again, moved over on the spectrum. And we started to ask more questions about trauma. And we opened up the requirements for trauma. It didn't have to be a natural disaster or something beyond the range of normal human experience. It could be situations that happen to people, like you say, when it could be rape, it could be assault, it could be very traumatic loss would be considered trauma. So there was the concept of what we call complex trauma, which are much smaller scale traumas, but they still have an impact on the person and the brain. And that's where we are today, talking about many disorders are related to even, but not just big traumas, but little traumas that have accumulated in a person's life.
Yeah, you remind me of the birth trauma concept and how a field can sometimes go in a variety of interesting directions in terms of treatment. I still remember when mental health professionals were pursuing primal scream therapy to help people get out the pain of birth trauma. We've experimented with a variety of interesting and sometimes cockamamie treatment directions.
Right.
One of the problems we've faced, I think, is the Diagnostic and Statistical Manual, the DSM, has had a number of additions, and they've improved as they move along, but they still are somewhat black and white and categorical. So either you have post-traumatic stress disorder and meet certain criteria within the DSM, or you don't. And unfortunately, trauma really, and the effects of trauma represents a spectrum. That there are a whole variety of impacts of trauma, and you can't just make it black or white. So just because a person doesn't have the PTSD or post-traumatic stress disorder doesn't mean they suffer from a trauma syndrome. And as you had mentioned, that we've now broadened the concept of trauma so that it doesn't involve a life-threatening, I think I'm going to die type of experience. In fact, people have even reported developing trauma from observing a loved one in the coronary care unit where they're hooked up to all sorts of IV lines and electrical beeping, et cetera, et cetera. And so one of the things we've learned about the brain is that despite the fact that it's pretty fluid and plastic and is always changing, it also can be very rigid. There's a part of the brain called the amygdala, which is a deep part of the brain. We've mentioned that before. That is a primitive part of the brain present in primitive animals like crocodiles, which go back thousands of years. And it's the part of the brain that stores life-related emergency experiences or experiences that are traumatic. So when you see the bear in the forest while you're hiking and immediately go into a fight or flight mode and the adrenaline starts surging, the experiences of that bear get stored in the amygdala. The real question is how long it gets stored, so that if you got attacked by that bear and ended up in a hospital and had a recovery period, my bet would be that you're going to have some flashbacks and experiences of that bear attack over time. That kind of traumatic experience is stored more tenaciously in the amygdala, and what happens is intermittently the amygdala releases the emotional experience and the memory. Individuals who have post-traumatic stress disorder suffer from that because they can be a Vietnam vet who is walking down the street and suddenly a car backfires and they have a startle response because immediately it brings them back to Vietnam when the mortars were landing and the explosions were going off and the traumatic experiences were occurring. But that part of the brain, the amygdala, can store this information, this experience almost indefinitely, and that becomes the problem. And so we've learned that trauma can be varied and exists on several levels. There can be people who have an automobile accident and for the next week or two or three may have some hypervigilance driving and be fearful driving or maybe even avoid driving for a period of time, but eventually they'll recover from it. So for most people going through traumatic episodes, they recover. The question that we need to answer over time, and I don't think the research has really provided it yet, is what kind of traumatic experiences get recorded in the brain indelibly so that it becomes something that influences our future experience and our future coping with life. And so trauma is something that we can't ignore and need to pay attention to.
And it's difficult because you can go through a trauma and not really demonstrate any after effects of it and think that, well, maybe that trauma was quiet and it's gone away and I don't have to worry about it anymore. But something a year from now or 5 years from now can actually bring it back to the surface, and then a person can become symptomatic, whereas they weren't before. Another tricky thing has to do with a number of years ago, probably about 20 years ago, people started to talk about this concept called past life regressions, which had to do with the idea that people may have had trauma in a previous life. And the clinicians who really believed in this concept would tell patients that even if you don't remember or have had traumas in the current life, you may have had traumas in a previous life that you don't recall, but those traumas might be affecting you. So they would regress patients in therapy to try to get them to recall what might have happened in a previous life. In effect, it looked like they were just planting seeds. And sometimes patients would remember things or think they were remembering things that really never happened, including assaults and rapes and other things. So very tricky stuff when it comes to trauma and identifying, was something real that was traumatic or was it not real? But at any rate, trauma is a range, like you say, David. It can be something huge and a disaster like 9/11, or it could be like the example of the person who goes to see somebody in the ICU, or it could be the person in the ICU. That's traumatic, to go through surgery or bypass or not knowing what's going to happen and being in an ICU recovery. So all of these things are traumatic. Not everybody will experience the symptoms from them, but it's up to us as clinicians to know if somebody comes in complaining of anxiety or insomnia or hyperstress reactions or depression, to ask questions about situations that may have happened recently or may have happened years and years ago, to see if it's related to the current symptoms.
What's impressed me the most over time in the folks that I've seen with trauma, and we'll talk some more about the different types of trauma, is the fact that trauma can serve as a nucleus for a variety of psychological psychiatric disorders. And so it's almost like outside of the trauma network, one can see the development of substance abuse. How much of that is to self-medicate the painful emotions related to the trauma that the individual is not aware of, but they suddenly find themselves that they're no longer in as much emotional pain when they use the alcohol, marijuana, or other more severe drugs. So one aspect of trauma can be substance use. Another is eating disorders, interestingly. And the question is, why would there be that connection between traumatic life experiences and eating disorders? Oftentimes, the type of trauma that individuals experience that lead to the eating disorder development is family of origin trauma. On a psychological level, one can understand that as perhaps a way of being in some kind of control. So if you can control your weight or control food that comes in and nobody else is controlling you, then that's a positive thing, even though it's maladaptive and potentially very, very dangerous. The other outgrowth of trauma is problematic relationships. If you go through repeated traumatic life experiences, it's difficult to believe that the world is a safe place. And therefore, you end up believing that you can't trust anybody but yourself. And oftentimes, it interferes with the ability to establish trusting, positive, healthy relationships. Individuals will end up picking social and romantic partners who are problematic in their own personalities and have maladaptive traits, etc. Maybe it's because they're safe. It's almost as if you come out of a traumatic experience and believe the notion that I'm not worthy, I don't have the value I should have. Rather than recognizing trauma for what it is, you internalize it, and that leads to negative self-image and negative self-belief systems. Mood disorders, as you suggested, can be an outcome of trauma. Sleep difficulties, etc. So individuals who are trauma survivors often don't flourish and they don't succeed in life the way they'd like to and don't know why. My experience has been once they begin to understand the impact of trauma, and there's a wonderful book that's been out for a number of years called The Body Keeps the Score that has been the most helpful book for a lot of people in understanding trauma. But once they understand it, suddenly it makes sense. And what that does is it sets the stage for the ability to, I want to work on improving this. I want to get rid of the negative effects of trauma and move towards a more successful life situation and kind of empty out the excess baggage that I carried with me since either childhood or young adulthood or even older adulthood.
First stage of psychological development, we all remember learning this in introductory psychology class, was trust versus mistrust. And assuming that in the first years of life, nothing bad happens, nothing special happens, the child starts to develop a trust. It's not that they're aware of this, but they develop trust that from day to day, everything is going to be okay. I'm safe. And that disappears when trauma happens, because now you go from a position of everything's going to be okay, no news is good news, to a complete opposite of that, which is I can trust. The 1 in a million does happen. Bad things do happen. And depending upon the age of this and the severity of it, and whether it's repeated, which it often is, especially in dysfunctional homes, trust goes out the window. And now a child and future adult goes into prevention mode. Don't trust. No news is bad news. Don't get comfortable, because if it's good now, any minute now, the shoe's going to drop and something bad's going to happen. So that gets into the nervous system, actually, and it goes from, in effect, what we talk about, a parasympathetic mode in the nervous system, which is kind of like a peaceful, relaxed mode, to a sympathetic arousal mode, which is watch out. So you become, in effect, like the soldier on the battlefield or the policeman walking down the street. You better watch out. And that starts to happen in general ways, undefined ways, but it can happen in relationship ways. Don't trust the relationship. Don't trust your partner. It can happen in don't trust that you're healthy. There's going to be something wrong with you. It can happen with money. Don't trust anybody. Put your money like they used to do, under the mattress. And you become, in general, a mistrustful person, which not only causes anxiety and even depression, but it really inhibits the person's ability to have a full life and to grow and to experience all of the good things in life, because they're on defense now. Our job is to help that person realize, you don't need to be on defense now. I use the story, I may have said it on one of our previous podcasts. There's a guy walking around sightseeing in Times Square, and he notices on the other side of the street there's a man walking around with an elephant gun. So he's perplexed by this, and he finally crosses over and goes up to the man and says, "Excuse me for being nosy, sir, but I notice you have an elephant gun ready to use it. Why would you have an elephant gun in the middle of Times Square?" So the man says, "Well, I don't mind telling you." He says, "I keep my elephant gun ready to keep the elephants away." So he said, "What do you mean keep the elephants away? Do you see any elephants?" And the man says, "No, you see it works, doesn't it?" And that is the concept, that if somebody doesn't have trust because of trauma, they develop that. And that may be in a vague, general, abstract way, or it may be very specific to certain people, to certain situations, to certain types of events, and they just never get comfortable.
Yeah, I treated somebody like that years ago. A fellow who was walking around downtown Fort Lauderdale with a high-powered rifle because of his fear of enemies approaching him, but that was due to a different kind of problem than trauma, although he traumatized a whole lot of people, including myself, when I had to treat him. But that's another story. One of the ways I think of conceptualizing trauma is to view trauma as having one form with a capital T and the other form with a small t. The capital T trauma is a classic trauma. I survived a plane crash, or I survived an IED in a Humvee in Afghanistan, or I survived a rape or molestation, or survived an armed robbery. Those are the big time traumas, and that doesn't mean that they're necessarily more severe. One of the issues that I've wrestled with over the years is take the individual who came out of a childhood where for years and years they were raised by emotionally abusive or even physically abusive parents. But let's take the emotional abusive parent as an example, because you don't really know that there was trauma, except there could be a parent who was always negative and self-critical and belittling you, etc. One of the last podcasts I told the Cinderella Part 2 story where Cinderella had to get rid of the belief systems that she developed in childhood. My belief is that the small T trauma can be as problematic, if more problematic, than the big T trauma. If you did an evaluation of Vietnam vets or even Afghanistan vets who were exposed to major warfare and combat trauma, not everybody develops post-traumatic stress disorder. In fact, the number of individuals who develop it is not the majority. There's some genetic reasons perhaps for that, but some people learn how to cope with it better. So the small T trauma is the one that falls through the cracks. They're the individuals who come into treatment with a mental health professional because of depression or because of anxiety or because of failed relationships or failed marriage. And if you don't look for the presence of trauma, then you're not going to be uncovering the core process that's causing the difficulties. You can help somebody recover from a failed marriage or problematic relationships, but it still will not change the fact that they're programmed to have problems in the future. And so asking questions about childhood and what was it like and what were parents like and what was the environment that you lived in like. And the individuals, for example, who grow up in the inner city where there's lots of violence and shooting, get subtly traumatized by that, and they need to be able to recover from it. And we don't have the capabilities now in our programs to provide that. So paying attention to the chronic, subtle, persistent trauma is very, very important and needs to guide treatment. And treatment can be effective for trauma now. It's more than just a primal scream. There are a variety of cognitive behavioral therapies that can be effective. One of the newer ones that is being utilized is EMDR, eye movement desensitization reprocessing therapy that can be very effective for trauma. And more clinicians, thankfully, are getting trained in this area. But first step, really, as we've discussed it, is to identify the presence of trauma and to be able to define the nature of the traumatic experiences themselves.
You know, with the little T trauma, one of the problems with that is that we talk about something called stress adaptation syndrome, which means basically we all kind of adapt to the level of stress that we have in our lives. And that's a good thing because some people have just to deal with more stress. So we learn to adapt to it. But that can also happen with repeated small T trauma, where a person, even though they know that these things that are happening can't be good and they're hurtful, they adapt to it because we're supposed to try to adapt to our environment, especially if we can't leave it. So what that does is it almost normalizes trauma, especially the little T trauma. So it's very important to be able to see that even if a person minimizes the importance of these little traumas and why they're having problems today, you know, our job is to help them realize, well, we don't want to magnify it and make it worse than it was, but we also don't want to discount its presence in why you're having symptoms today. We do have much better methods to help people who have had trauma in their life and to help reduce the effects of those traumas on current symptomatology. Some of it is, as you were saying, David, cognitive behavior therapy. Some of it is psychopharmacology. You know, there's interesting research now that shows that depending upon the severity and the type of trauma, it can even become intergenerational, where there's actually some impact on DNA and it can show up somehow in derivative form in the next generation. I mean, clearly that's happened as a result of the Holocaust is a perfect example of that. So trauma is a big deal. And even though many years have kind of gone by in the field of mental health where we minimized it and required a different kind of perception of it than we have now, it is a big deal. It impacts on people in many different ways. And it's our role to look at it and it's our role to educate not only the patients who come to see us, but the public in general that trauma is the real deal. And it's not a form of trying to blame anybody or anything. It's just our efforts to try to help people realize some of the things that impact on one's mental health.
And I fear that we're entering into a new era of that small t trauma, and that's the era of social media, artificial intelligence, and chatbots. I mean, think about the individuals who have ended up becoming self-destructive in response to chatbots that they interact with. Um, the brain is very plastic, and brains are gullible. And I really worry about the impact of uncontrolled social media on the development of traumatic experiences from the type of input that they're getting, especially in younger people where their brains are still developing. And you can easily develop misconceptions about the world, misconceptions about yourself, similar to what happens to young people who develop eating disorders because of all the exposure they have on social media to the importance of being thin. And there are actually websites where they talk about the value of eating disorders and uh, anorexia or vomiting or bulimia, where you end up gorging yourself with food and then inducing vomiting. So social media, I'm afraid, and chatbots and AI is going to lead to a whole new generation of traumatic experiences that we need to pay attention to and not ignore. The good news with all of this is that we've become pretty sophisticated and we're no longer as rigid in viewing trauma as a black or white experience, but instead of as a spectrum. And hoping that individuals who are listening to the podcast will think back in their lives and think about whether or not they've been exposed to significant trauma. And if they have, it's important to reach out for help and get some help in that.
Well, I think this was really, I'd like to think of our talk today on trauma as a first step. I think there's a lot more we can say on it, and both in terms of the types of traumas that can affect people and maybe get more into the different methods that we have so that people can really feel more comfortable with dealing with whatever traumas they might have and to feel like they don't need to bury it, they don't need to hide it, there's no shame involved. It's just part of the human experience. And just like good things, there are bad things. And if we can try to help people who have gone through some of the bad things, I think people will lead happier, healthier lives. So I'm Dr. Andrew Rosen, psychologist.
And I'm Dr. David Gross, psychiatrist, and we are Two Shrinks and a Mic.
Thank you for being here.
Bye-bye.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.